What I have here is just an epidemic curve of what's going on in Middle Tennessee. And I understand not everybody here is Middle Tennessee. So we're going to get to another one in just a sec. I mean, everybody's Middle Tennessee, but not, like right around Metro Nashville. What this just shows is, in the recent past, what is the trend in case reports, which is a case when somebody's diagnosed with COVID. And so the big one, of course, is Davidson County. And then this one here is Rutherford County. And everybody else really doesn't have much. You can see Sumner County, when they had that nursing home outbreak, they had a few deaths and a few more cases, but they've been quiet since then. So basically, this is pretty good news for most of Tennessee. There's not a lot of COVID activity or spread going on. This is from data in the Johns Hopkins COVID tracker that they update daily. And I've been watching this and watching other data sources, and they line up well. So I think this is a good view. And anytime anybody has a question, just throw it out.
Okay.
Okay, so there's also, I'm going to click on this one. This one is from the State Department of Health, Tennessee, and here you can get to other counties. So like we could come look at Montgomery County, but here we go, county. And let's get to Montgomery. And here's their version of the same thing.
I'm not seeing that map.
We have resources and red flag screen up.
Oh, you're not seeing, okay, let me try again. How about now?
I see it.
Okay. Yeah, so what this does is this is from the State Department of Health, and you can pick different counties and it'll show it to you. So let's see, what other county might we want? Anybody have a county they want to look at?
How about a county? Anybody?
Williamson.
Okay. So yeah, we're seeing in Williamson County, just not a lot of new cases.
Okay.
And then in here, there's a link that you can follow. So I mean, I assume this will go around to folks, and then you'll have the link and you'll be able to go look whenever you want.
Okay.
All right, and so then the question is, well, what are some, I asked, what would you want to know? And one thing I was told is good resources.
Mm-hmm.
And, there's pretty good resources. The PCUSA stuff, I looked at that, it looks good. CDC.gov is the official. I mentioned the MMWR, which is the Morbidity and Mortality Weekly Report. And that's another thing that people can sign up for and get.
Rachel, that screen isn't showing. We still have the epi curve.
Huh, I thought I told it to just, sorry.
That's okay.
That's all right.
How about now?
Perfect.
Okay, now I'm going to do one other thing. Do you have the epi curve back again?
Yes.
Okay, now we got it the way I thought I had it all along. Okay.
Okay.
All right. And then, a lot of people have probably seen the Johns Hopkins COVID tracker, and that one's good. ScienceMag.org is, I've enjoyed that. If you're really interested in the nitty-gritty details, they're pretty good. And all of these sites, like if you go to ScienceMag.org, they have a bar on the top that says, for your COVID stuff, come here. All right. And then another thing is when you're looking at epidemic curves, you just want to consider the impact of localized outbreaks. So for example, prisons or occupational things. So there could be a county that has a large number of cases, but they're not really community spread. And for churches, I would think that the community spread would be more relevant than, you know, those isolated outbreaks. And we'll look at an example of one of those. Is it Loudoun County that had?
Trousdale.
Trousdale. Okay, I think Loudoun had one too, where it's a blip, right? And then, yeah, we are seeing some pickup. Trousdale. Yeah. So, you know, you get the blip, and is that affecting everybody else who lives in Trousdale County? Not so much. Another one I'll point out is Davidson the last 2 days. Oh, they fixed it. Okay. Yeah, they had a blip in their data where they had 0 cases reported for 2 days, and it was like, well, that's not right. And sure enough, they've fixed it. So if you have something that looks like this, and then all of a sudden you get a couple days of 0, that's a mistake. It's not real. All right, and then, you know, the red flags, you know, what are things that I discount? Anybody who says they know what's going to happen, at this point, we don't know what's going to happen. So predicting the future is very difficult or impossible. And the other thing we've heard some people talk about is, you know, the plan is to just let everybody get sick. And, you know, we might get there. I'm not saying that that's impossible. It's just that we've had some locations like New York and Italy and England, and France and Spain that have had really tremendous outbreaks with a lot of mortality. And they're still far from herd immunity. So if our plan is herd immunity, our plan is to let a lot of people die. Which, you know, that could eventually come to pass, but we're not, I'm hoping that it doesn't.
Yeah.
All right. All right, and then the other question that's really important is how does COVID spread, or the novel coronavirus? And it's person to person, which is that's why we're on Zoom. And another thing is there's this concept of dose, and people understand dose of a medicine, but there's also the dose of exposure. And a really small exposure is very unlikely to make somebody sick, okay? So it's not just person to person, like that's why they say within 6 feet for more than 15 minutes. That's your dose of exposure. So when they do contact tracing, they're not looking for everywhere they are looking for everywhere you've been, and then they're really worried about the people that you were close to for 15 minutes. So it's important not to be afraid of every little thing, because every little thing is not where the risk is. The risk is being together in close proximity for an extended period of time. So the example I have is a grocery store worker or any worker is more likely to be infected by a contagious coworker rather than somebody who's just walking through the work area. That's not a super high risk, but if you're with somebody for a whole shift, that's a higher risk. Of course, we still don't know a lot. And this is part of what makes it really hard to predict the future. We know that asymptomatic and pre-symptomatic people are sometimes contagious. We know that sometimes there are super spreaders. And we know that super spreaders, there seem to be some people who are just really good at spreading the virus. And we don't know who they are. You know, they're people, we don't know which ones they are, and that makes life difficult. And then you find out later that there was an event at which 16 people were infected. I've heard some people say that 20% of COVID patients are responsible for 80% of new infections. It's just that we don't understand that dynamic yet. Okay, so precautions to prevent the spread. And anybody who's worked in healthcare knows that there's two separate kinds of precautions that they use in the hospital. One is droplet precautions and the other one is airborne. And what we've been focusing on in the United States, and actually the World Health Organization too, is droplet precautions. And droplets are produced by coughing or sneezing. They're small, and they're not as small as, aerosols, and they settle quickly. Like within 15 to 20 minutes, they're gonna fall out of the air. And they don't go real far. So that's why they say 6 feet of social distance. Another advantage of droplet precautions is that they're fairly easy to implement. You just tell people, cover your coughs, wear a mask, stay away from people. It's achievable. It's something that we can do. The other kind of precautions is airborne precautions. And that's the kind of precautions you use for people with tuberculosis or measles or chickenpox. And that's for particles that are produced not just by coughing or sneezing, but quite literally by breathing and by talking and by singing and laughing. And you don't have to cough, and you can produce aerosols. While droplets are small, aerosols are really, really small. And they stay in the air much longer, like hours, okay? And because they're in the air much longer, they move much farther. And they circulate with air currents. So where you are in relation to the air current matters. So in a hospital, this means that you put the patient in a negative pressure room, and all of the air that that patient is breathing is exiting the room through a filter that's removing aerosols. Anybody who goes into that room who's a staff member wears an N95 mask. And so that's how healthcare people think of airborne precautions. With airborne precautions, a cloth or a surgical face mask will limit spread from the wearer, and it's probably going to help somebody who's wearing a face mask. It'll probably help prevent transmission of aerosols, but they're really small, okay? And if you happen to have a decent sized dose of aerosols right next to you when you're wearing a cotton face mask, the cotton face mask may or may not protect you. So that's the difference between droplet and airborne. The other thing, of course, that happens with airborne precautions is that they're not achievable, okay? I mean, they're hard to maintain in a hospital, and they're not achievable in the public world. So then the question is there airborne transmission of COVID-19? And the answer is frankly, yes. All right. There's been many documented cases of airborne transmission of COVID-19. And then most recently, we're starting to see, reputable scientists come out and say, look, guys, you keep talking about droplet precautions, but we're dealing with an airborne disease. And they're like, this isn't working, it's a problem. The JAMA article was kind of oblique. It didn't come out with quite the same force as the other two that I have listed there. And then other people, it's becoming clear that our adherence to this droplet precautions is good, but it's not the whole story. And I think there's a couple reasons for that. One is because they're not achievable. You can't do it. So you can't ask people to do something that they can't possibly do, right? I mean, it just, doesn't work. Even healthcare facilities, given the volume of cases they've seen in some places, can't do airborne precautions. So if we tell people you got to do airborne precautions, oh, but you can't, it just doesn't feel right. In addition, the 6 feet and the droplet precautions go a lot of the way towards reducing risk. So, you can do that, and you've taken some really excellent steps to prevent transmission of COVID. So that's another thing is that, droplet precautions aren't bad, they're great. It's awesome, and we can do it, we can do that. But it's not gonna eliminate risk. another thing that happens is that if we start to kind of tell people, look, this is airborne, we might be able to maybe, I mean, I don't know, maybe we'll have more acceptance that universal masking is important. Because universal masking is going to be really, really useful if you have somebody who's contagious and doesn't know it, but they're already wearing a mask, then that's a good thing. All right, and then we have the, this is one of the examples that's, you know, probably airborne transmission, singing. And I suspect laughing is going to be in the same category. Yeah. That, you know, this was one choir practice with one person who was infected, and 87% of the group developed COVID. And 3 of them died, by the way. And that would not have been prevented with droplet precautions. So. All right, I have another video here. So masking, we got a fun video. So what you're seeing there, all of those little green dots are droplets coming out. Okay, now they're going to put a mask and the person's going to speak. They're just speaking. That's all they're doing. And the point of this video is visualizing speech-generated oral fluid droplets with laser light, right? So it's just showing what happens when you put a mask on somebody. When you put a mask on somebody, their emission of particles, and they're just speaking. You know, they're not coughing, they're not sneezing, it's just speaking. All right. It looks like cloth face coverings, like the kind that I have and that I use when I go out, are basically just as effective as surgical masks, which are the kind that, you know, like this is a surgical mask. And then we really don't have the supplies for N95 masks for the general public. And then this is showing the right way to wear a mask, covering your nose and going below your chin. So universal masking is probably more important than we've kind of let people know. I don't wear a mask if I'm walking down the street and there's nobody around me, but anytime I go where there's people that, you know, aren't my husband, I wear a mask. Okay, and then there's another kind of precautions that people probably know about, contact precautions. And the virus can spread with touch, doorknobs, cans, whatever people are touching. And again, contact precautions are really hard. People touch things and then they move around, and you know, we just can't keep everything clean. When we are cleaning, another thing to keep in mind is if you're using a cleaner, you don't just put it on and then dry it right away. As the cleaner dries, that's when it's killing whatever it's come into contact with. So dry time is kill time. And again, just to stress that the guidance is that the primary method of exposure or transmission is person to person. And so, you know, dose of exposure matters, the route of exposure matters. I mean, I do wash my hands, I do clean things, but I don't think that we're going to stop the spread of COVID-19 just by cleaning surfaces. That's not the big risk. And then we all know this, so I'm just saying it again. Mortality is much higher among the elderly and among the sick. And so we know that. And also that, we don't know about long-term outcomes, and that when people get sick, they can be at risk for hospitalization for quite a while. All right, so an oximeter is this thing. And I just put this slide in here because a lot of people don't know what they are. And I think people should realize that these exist. I think it's an important thing to say, oh, this exists, and maybe I should get one. They're easy to use. You can order one from Amazon for 30 bucks. I looked yesterday and they were still in stock. And the reason to get one is because the patients who are getting really sick and dying, frequently it's because they don't realize how sick they are. They don't realize that their oxygen sats have dropped. Typically when people's oxygen saturations drop, they're also retaining carbon dioxide. And then they have these receptors in your brain say, oh, wait, you're not exchanging gas, you have a problem. But in COVID, that doesn't seem to happen. It seems like their COVID patients seem to be able to exhale carbon dioxide just fine. They're just not bringing in the oxygen. And so then they don't realize that they're losing their ability to breathe. And then when they show up in the emergency room and they have the super low oxygen sats, the doctors start going, ah! All right. So it's in addition to the thermometer, this is a useful diagnostic thing to have in the unlikely event that you ever do need to monitor somebody's oxygen saturations. But I mean, if you did need to monitor somebody's oxygen saturations, it'd be nice to have it. Another thing is that I'm going to get a flu shot this year, even though I don't usually. And then the reported progress on COVID vaccine development has been very good. So while initially I was like, well, I don't know, but it looks like there will be a vaccine, hopefully as soon as possible. All right, and then, just again, the unfortunate truth is that generally church events are longer than 15 minutes. They're usually inside. Interacting with other people is definitely a part of church. And a lot of church members are older and at high risk for illness, which just is going to make this hard. And the cleaning is useful, but staying apart is the key ingredient to reducing transmission. Now, the only good news is that in many counties, there aren't that many cases. And yeah, I have no complaints about places where there's very low case counts. I mean, if nobody has the disease, you can't get it. So that's also true. I mean, here in Nashville, it's around. We have kind of consistent, we've plateaued, and there's not tons of COVID, but it's around. But then in that one county we looked at, what was it? Let's just pick a county. Yeah, I mean, there's one case every couple weeks in Campbell County. So yeah, Campbell County, they could probably have church. Davidson, yeah, we're up in the 70 to 100.
Wow.
Yeah, it's different. Let's see. Oh yeah, and then the final thing is just that we don't know what's going to happen. I mean, we can kind of tell how many hospital beds we're going to need in the next 2 weeks, but yeah, otherwise, not so much.
Rachel, would you please go back and look at Montgomery County and tell me what you see?
Yeah, so there is consistent diagnoses in Montgomery County, not a lot of them. I mean, 4 a day on average. So, I mean, it's there, it's clearly spreading, but it's rare. And then, you get those places where it's borderline, you don't know. It's hard to say.
Well, if you look at the number of people in the county versus the number of cases, See, most of our citizens live in the city, about 170,000. So what kind of a recommendation would you make to a guy like me? I do have a science background. What kind of recommendation would you make to me to pass on? Because we're right now, this afternoon at 5 o'clock, the committee of which I'm a member is meeting to talk about this.
Well, I think it's,
Reopening.
yeah, I think it's important for people to know that there is, in Montgomery County, there's no guarantee that there's no exposure. But, you know, the risk is going to be pretty low. So, I mean, I think that you could say, you know, we could reopen, but we still might really encourage people who are high risk to stay home. And, you know, the universal masking also, I think, helps a lot. So, yeah, I mean, I think that reopening is not a crazy thing to do. But doing so, being aware of the fact that, and keeping an eye on this. So that would be another key component, would be to keep an eye on this. So keeping an eye on this, looking at it, saying, well, if we give above 10 new, on average 10 new cases a day, then yeah, we don't want to stay open. But if we're under 10 new cases a day in Montgomery County and we have universal masking, and we make sure everybody knows that you know, if they have any concerns, they should stay home. I mean, that's a borderline call. It's not a crazy thing to do. Reopening would not be crazy, according to me.
So if we do reopen, can you give us some steps to take, things to consider, how we are going to do worship differently from the way we're doing it before COVID-19?
I'd probably defer to the guidance from PCUSA.
Mm-hmm.
I know that they say, for example, you know, like coffee hours out, and you know, the basic things like that, communion, I can't remember. Yeah, Robin can say what that is.
Yeah, I'm just gonna see if we could see people again, maybe. There we go. I think, was that Joel that was asking that?
Yes.
Yeah. So we've sent out the guidelines, PCUSA on the PCUSA website, and then we also have sent out the CDC guidelines, you know, to follow those, you know, and again, being sure to take care of those who are most vulnerable, our elderly and the folks who are sick. If you're feeling sick, stay home. It depends on how, you know, again, then you're looking at spacing out in the sanctuary, singing, no singing, wiping everything down, requiring masks. We've seen no bulletins. I'm trying to think. Yeah, did you get some of those links?
Yeah, I've seen those.
Okay.
One of my questions, one of the things that I haven't seen addressed is any kind of tips on communion.
Yeah,
Don't
I'm sorry, say again?
do it.
yeah.
Don't do it, okay.
Yeah, what we've seen is some churches, you know, bring your own,
Mm-hmm.
you know, but yeah, and also offering. You don't want to pass an offering plate.
Right.
You might want to
Can I-
keep, you know, something, a common container in the back.
What we have decided to do when opening comes is we're going to have a bread and a cup up front, and I will say the usual words and raise each element in the air, and we'll have a moment of silence with nothing passed out.
Mm-hmm.
So we'll kind of follow John Calvin to the extreme and have communion symbolically.
Yeah.
And then for the collection, we'll just have a collection container, one that people will drop their collection into. We haven't worked out yet exactly how the line will go with that, or if we'll have people do it throughout the service to keep people apart. But that's how we decided those two things.
Mhm.
Can this be done remotely when they're putting it on YouTube live? We could do our own juice at home and cracker, or what?
We have done that already, have them do that at home.
Okay.
That's just us.
Well, you can say the same words. We're just not sitting in front of him rather than.
The denomination gave us the okay to do that a couple months ago. So
Okay.
yeah, you can have the ritual in the church and invite people to have their own juice-like substance and bread-like substance at home.
Okay, good. Thank you.
My question to you, Rachel, was when you said this year you're not going to do you're going to have a flu shot. Is that just so that because if you got the flu, you'd be more susceptible to COVID?
No, it's just because there is, obviously concern about a resurgence of COVID, particularly when people are spending more time indoors.
Mm-hmm.
And we don't need to add any additional illness to the mix. So it's not because there's any known reason to worry about flu and COVID together. It's just because there is concern about having enough hospital beds during the winter.
Yeah. Any other questions for Rachel?
We had a question about whether if you want to attempt congregational singing, but people are masked during the congregational singing, would that be a safer practice, or just no congregational singing at all?
I'm not aware of anybody who's looked at that, so I don't think I have an answer. It's a question that, we could Google basically and see if there's anybody who's looked at it, but I don't know.
I have a question. Our church has a balcony that kind of wraps around 3/4 of the room. And church members said, well, we could spread out by putting people in the balcony. And I thought about that, and it seems like you would be putting people upstairs that could just spit further out into the yard. They become these lawn sprinklers of COVID. I mean, am I off base there, or what are your
I don't
thoughts?
think so. There have been studies looking at airflow in enclosed spaces. There have been a couple well done in South Korea and in China where they had occupational exposures, and they clearly showed that, and those are some of the things that clearly show airborne transmission, that in the areas where people were even sitting fairly far apart and they knew where the index case was, and everybody who was downwind ended up, not everybody, but that's where the infections appeared. So yeah, the direction of the air movement inside matters. And you'd have to figure out what is the direction of air movement in your space. And then you start asking yourself, do I want to take that risk, or do I want to wait?
And a follow-up question to that is the HVA system. I was wondering if, what if we crank the temperature down and dried out the air as much as possible? Would that help hinder the virus?
Not as far as we know.
Okay.
There is recommendation for, more air exchanges, but in terms of temperature or humidity, I'm not aware of anything that says it makes a difference. And like a lot of churches, they're big spaces, so doing a complete air exchange might not be, a certain number of complete air exchanges per hour might not be achievable. And you certainly have to spend some time figuring that out.
And then I think I've also seen where once you have your folks back into the building, it's recommended to clean the entire building all over again, right, Rachel? Is that what you've seen?
I mean, that's looking at the contact precautions. And I mean, people touch things all the time. And yeah, the other thing is COVID doesn't seem to live very long on surfaces. So that, you know, like the problem isn't you have church on Sunday and then you have another event on Wednesday. Everything's gone by then. I mean, the dose is probably going to be so low by Wednesday that it doesn't matter that much. The problem is people show up on Sunday and then they touch something, and then somebody else comes on Sunday and they touch something. So it's more the short term, like they're in the same place at the same time, touching the same object, rather than, okay, everybody's gone, now let's clean everything so we'll be ready for next week. Does that make sense?
Yeah.
Yeah.
That's cool. Oh,
Paul's muted.
yeah.
Yeah. What I'm hearing you say is that the idea of maybe wiping down the pews between Sunday services may not be that necessary as much as it is making sure that we keep people apart while they're at the service.
Yeah, and masked.
And masked. But frankly, I'm hearing you say that it's not that wise even to attempt it. Now, we're following the Metro opening plan, and we've decided that we're not going to pursue opening until phase 4 of Metro Nashville's reopening plan. I think that gives people a sense that it'll be better then and safer then, so we can open. But what I'm hearing you say is that that isn't necessarily the case, and that getting any group of people together for a period of time is going to be risky indefinitely. Would that be, am I hearing you correctly?
Yeah, where there is community spread of COVID. And in those places where there's no community spread, you'd have to have somebody come in from outside who was contagious. But in places where there is active community spread of COVID, it's going to be hard to gather people safely. I mean, you can reduce the risk with universal masking and things like that. And you know, is it feasible for everybody to just quit for, you know, months and months or a year? I don't know. I mean, there's the whole thing of what's possible and what's achievable.
Thank you.
I had one other.
No, I mean that's helpful. That's helpful. Thank you.
Go ahead, Phil.
I had one other question. In my anecdotal sampling, when I do have to go out with my gloves and mask on, in our county, I see about 1 out of 11 with any protection at all. Does that, now obviously that's anecdotal, but I've done it several times when I've been out on various duties. Does that give you pause to reconsider my point about Montgomery County, or does it make any difference? If we assume, and I know it's anecdotal, but if we assume that roughly 1 out of 9, maybe 1 out of 8 are doing anything about it to protect them, does that offset anything you said about Montgomery County?
Well, I mean, this is where, you know, this is where I'm saying I want people to know that it's probably that the airborne risk exists. Because then, one, people can make their decisions knowing what their risk is. And knowing that, you know, the 6 feet of social distancing is probably, it's not going to be like a guarantee that you're not going to get infected. But yeah, it's the same thing. People are not masking, and when there's more community spread than there is now, I mean, now there's not that much community spread, even in Nashville. It's here, it's spreading. We're getting, you know, 70 to 100 new cases a day, diagnosed new cases a day. And, you know, some people are going to be like, yeah, I'll take my chances. I'll go out, and other people won't. So but yeah, definitely when we start getting more community spread and people aren't masking, it will contribute to new cases. Yeah.
I'm
Me.
I'm late to the show, but I have a question about the future. What you may have already talked about this. What about the second wave?
Yeah, we don't know. We know that it's not gone, and we know that there's still plenty of susceptible people. But how that's going to happen, we don't know. There was a group out in Washington State that did some really interesting modeling early in the pandemic. And they were a very respectable group that has a lot of disease modeling experience. And they were completely wrong about what was going to happen. So basically what happened is New York and New Jersey had many more cases than these guys predicted, and everywhere else had many fewer.
But we don't know about a reoccurrence then.
No, we don't.
That's the scary thing. We can take care of now, but we don't know what's going to happen in 6 weeks or 8 weeks or 3 months from now.
I'd be surprised if we had another New York, just because of the testing that's going on now. I think that we'll become aware faster if there is another wave where you get another increase in cases. I think we'll know about it faster.
I'm personally a high risk person. I've got all the markers for high risk. So that worries me more than, I can take care of right now. But I get out there, everything seems to be okay, and the wave is lurking in the shadows.
Could it be that some of the numbers and things like Phil was talking about Montgomery County, we also don't have a lot of testing going on that I'm aware of. In fact, I personally don't know anybody that's been tested. So we could have cases that we don't know about. So that also is a concern to me. You get the children or you get the adults together, the younger ones that might not be affected so much. Nobody's being tested, so we really don't know.
Yeah, I understand that. But I mean, COVID, if it's doing a lot of community spread, it is going to stumble across some susceptible people who are going to get very sick. So, I mean, that could happen, but eventually people are going to land in the hospital and you'll know about it.
Gotcha.
Do you think that people will be more alert to testing everybody who goes in the hospital? Because there were a lot of people who wound up, sick, and some of them died, and nobody knew about the COVID at that point.
Yeah, maybe. I don't know. I mean, there have been some studies where they do a blanket testing of everybody. But we're not doing it very much here. And the value of that, it's hard to know.
Am I misunderstanding you? Are you skeptical about testing in general, or just type of testing?
No, I'm not at all skeptical of testing in general. And in fact, I think that, the ready availability of testing now is going to help prevent another New York or New Jersey, where you had, massive spread, massive, overwhelming of the healthcare system and all of those consequences. So I'm not skeptical of testing. I think that the value of testing everybody is unproven. So, I mean, I can understand why people haven't decided to do it. I mean, if I had a cough and a sneeze that didn't go away, I'd go get tested.
Me too.
And I know I heard on the news the other night that because of the protesting downtown Nashville and the close proximity of everyone, they're wondering in 2 weeks, will we see a spike, right? I mean, folks weren't wearing masks. Some were, but people were very, very close to one another. Lots of people.
Yeah, and we don't know.
Yeah.
By the way, I found out something this week I had not heard, that St. Thomas Midtown is doing testing. You hear about the ones on TV, but this is never mentioned. And that's where I went out and got my test. You have to go through a process like you do with them, with the city. You call in and they give you they make up a notation of you, and then when you get there, they run you through the process.
Yeah. Well, Rachel, we so appreciate your wisdom and your resources, the data, and just having this conversation. And again, we don't know. There's so much that we don't know, but just being able to talk about it, I think that really helps a lot. Kind of.
Yeah, sorry, I don't have more answers. And I see that Mike sent this about singing, so there's more information there.
Oh, I didn't see the chat. Great. That's great. Thank you, Mike. Yeah. All right. Well, thank you all for joining us and being with us. And Rachel.
Thank you for doing this. This is good information.
Good.
Good. Yes. Thank you so much, Rachel, for providing us information. It's good to have somebody that we can trust and turn to for some of those resources, some of that information.
Yes, thank you.
Yes. Yes. Well, stay healthy, everyone.
Thank you all.
All right.
Okay.
Bye-bye.
Thank you.
Thank you.
Thanks, Rachel. Thanks, Robin and Ray.
Thank you. Thumbs up.